Welcome everyone to the first meeting for 2022 for the Sacramento County Opioid Coalition. My name is Lindsay Coate and I am co-chair of this coalition along with my other co-chair, Janet DeMonchel. I'm going to take just a moment to introduce the members of the executive committee. We have Dr. Melody Law, Lori Miller, Dr. Andrew Mendonca, Sean Vassar with the U.S. Attorney's Office, Jamin Martinez, Lieutenant Jamin Martinez, Ashley Zaru, Drug Intelligence Officer with HIDA, Ranjit Diwali, Nick Morey, Ed Juke, and Jamie White, Lori Slothauer, all with Sacramento County, Mark Ott, the Deputy District Attorney, Dr. Olivia Kasiri, our Public Health Officer, and Samantha Mott. And finally, we have our new AmeriCorps Vista, Lauren Werner, who is on this call as well. So to get things kicked off, I see Lori is logged in. I'd like to introduce Lori Miller with Sacramento County Alcohol and Drug Services, and she's just going to take a few minutes to share some updates with you. So Lori, please take it away.
Hi everyone, and happy Monday. I'll go ahead and share my screen here for a couple of updates that we have coming up. Let's start with the fentanyl town hall. So we have a fentanyl town hall coming up, and this is a partnership between the Sacramento County DA's office and the Substance Use Prevention and Treatment Unit of Sacramento County. And the town hall is scheduled for this coming Thursday, January 27th. And this is kind of a new process for us. We're actually going to be live streaming this on YouTube. We will have a panel of health officials, elected officials, law enforcement, and some family members impacted and lost their child to fentanyl poisoning. And so much similar to our fentanyl safety fair that we had at the state capitol, the goal of this is really to just raise awareness and education in our community, share with folks how to administer Narcan, have a conversation with all of our panelists, asking, having the public be able to ask questions, get their questions answered, and then continue with our campaign efforts around addressing fentanyl here in Sacramento County. So the event is from 5 to 6:30. And again, there is no Zoom link. I want people to know you'll just have to log into the onepillcankillsac.com website, and then you will see the link to get into the live stream. Okay, thank you very much on that one. And then we have my next announcement is just on our Methamphetamine Coalition coming up in February. And again, Lauren, if you have an opportunity to share that one, it is scheduled for February 10th from 2 to 4 p.m. And this one will be held on the Zoom platform. And we have an agenda that's also scheduled, and we will be focusing on some updates, variety of different areas. We have the high intensity drug trafficking area that would be providing us an update, as well as a focus group from our local marketing firm that helped us with our Let's Talk Meth campaign effort. And so we will be just breaking out really quickly in the beginning and assessing how our letstalkmeth.org website, how you guys are feeling about it as a coalition. Are we moving in the right direction? Any other comments, questions, concerns around how we can improve the way we're addressing methamphetamine here in Sacramento? So hopefully all of you are able to attend that one because your voice really matters in this effort. And although, of course, opioids and fentanyl are on all of our minds right now due to the increase in overdose and poisoning deaths here in our county, we don't want to lose sight of methamphetamine, that it continues to impact all of our departments across the county. So, I encourage all of you to attend. We appreciate the support that many of you have given us in this coalition effort. And so we hope to see you on February 10th.
Okay, up next, I believe that we have Ashley with HIDA, and I'll let her introduce herself.
My name is Ashley. I'm the Drug Intelligence Officer for Central Valley HIDA, which stands for High Intensity Drug Trafficking Area. I will go ahead and share my screen. So All right. So Central Valley HIDA consists of 14 counties, and we basically have the entire Central Valley. Sacramento is one of them, and Placer and El Dorado as well. So they're kind of our three that are right within Sacramento. So what is HIDA? Well, it's a federally funded program through the Office of the Executive Office of the President in the Executive Office of the Drug Control Policy. So there's kind of a lot of different layers going on here as well. HIDA is specifically within the overdose response strategy. So as a drug intelligence officer, I report directly to the overdose response strategy, which is a nationwide program. So kind of basically what I just said, HIDA bridges the gap between public health and public safety. So not only do we work with local law enforcement and state and federal law enforcement, but we also work with hospitals and coroner's offices and the CDC, just so we have a more accurate reading of data and statistics regarding opioids, meth, heroin, marijuana, pretty much any drug. The national map on the left side is all the HIDAs across the country, including Puerto Rico and the U.S. Virgin Islands. There's currently 33 HIDAs within the U.S. and on the right side is the Central Valley HIDA. So all of the highlighted areas there is our jurisdiction. We also have some tribal lands as well. So not only do we have counties and police departments, but we also work with tribal law enforcement areas as well. So what's my role? Basically, I establish points of contact between coalitions such as this coalition and federal and state and local law enforcement. So they can kind of get a reading on what's happening in the community, where are large areas of overdoses happening. Sharing that intelligence throughout the HIDA jurisdiction is really important so we can have a more real-time and accurate reading of what's going on within Sacramento County, Placer County, all of our 14 different areas. And then we also want to improve the effectiveness and the efficiency of the Central Valley, just making sure that there is communication happening among law enforcement and there is communication happening from law enforcement to public health as well. So that's kind of my role. And that's pretty much it. Does anybody have any questions? Kind of a lot to go over in a short amount of time. No? Okay, I'll drop my my contact info in the chat so everybody has access to it.
Nice to meet you, Ashley. Look forward to working with you.
Yeah, you guys as well.
Thanks, Ashley. I appreciate it. All right, so we're going to go ahead and get started with the bulk of our agenda. So today we're going to be really focusing on youth strategies in working with youth on educating about opioid misuse. And we have an action-packed agenda. So we're going to get started with Dr. Andrew Mendonca, and he oversees clinical and program operations for Sacramento County Substance Use Prevention and Treatment Unit. And for over 15 years, Dr. Mendonca has been actively involved in the fields of substance abuse, mental health, and forensic psychology. He is licensed to practice in over a dozen states and has presented topics around the nation and the world, including in Canada and Europe. He has been featured in countless national media, including Forbes, USA Today, NBC News, NPR, and the HuffPost. Discussing topics such as suicide, mental health, and substance abuse. So today, Dr. Mendonca is going to be talking to us and giving us an update on opioid data and youth-related findings. So Andrew, please take it away.
Great, thank you, Lindsay, and thank you for the opportunity to present today. So I'm just going to give a pretty high-level overview for some of the data that's coming out of Sacramento County, California, and across the nation, and then I'll be handing it off to my colleague, Tricia Parker, who's going to be doing a little bit of a deeper dive into some of the data and trends and some of the pulse that we're hearing of what's going on in Sacramento County related to some of the trends of youth substance use. So let me go ahead and get started, and I'll put my information in the chat as well when I finish up. So you're welcome to reach out if you need a copy of this PowerPoint or have any questions or anything I can answer. I'll put my information in the chat. So a recent article came out, wanted to highlight for everybody. Recent surge in drug overdose deaths have shocked everyone. We have about, across America, about 100,000 dead between the April 2020 to April of 2021. First time that that the figure has topped six figures. We know that the pandemic has not helped whatsoever in the opioid epidemic and the drug use across the nation. And so we're continuing to see numbers increase while we continue to be in a pandemic and continue to struggle with COVID. A lot of folks are using drugs more than they intended to, or taking up different kinds of drugs just because addressing either self-medicating or for a variety of reasons. So we certainly are concerned about this as what we're seeing here in Sacramento County. We're continuing to see, like I said, across the state and across the nation. So this is certainly a national epidemic that we're experiencing in regards to opioid increase in use. The journal Drug and Substance Abuse published in December 16th of last year that fentanyl overdoses became the #1 cause of death among US adults ages 18 to 45, and they're declaring it in a national emergency. And again, for any of us that are involved here in Sacramento County or working in work groups in our neighboring counties, we know that this is not new to us. We are seeing this, we're seeing the effects of this every day out here in our communities. And more adults between the ages of 18 to 45 died of fentanyl overdose in 2020 than COVID, motor vehicle accidents, cancer, and suicide. So again, this is something that we really want to take to heart and make sure that we really recognize just how quickly this cause of death is surpassing the other causes of death that typically, have taken the lion's share of death in our community. So here's some data I'm going to present for the next couple of slides. This data comes from the Sacramento County Coroner's Office. This is the most accurate data that we have at this moment. It's only a couple days old that I was able to receive it, so I wanted to share this data with you. Here in the data, we're showing about 110 fentanyl-involved deaths, and this is specific to Sacramento County, and again, the cause of death from the Coroner's Office. As you'll see, the red are females and the blue are males, and we're seeing here ages 20, 30, and 33. So that kind of grouping of age accounts for a large majority of the deaths in Sacramento County. But really, when you look at the numbers, really what separates high versus not high are only 1 or 2 deaths. So really, if you're looking at this, from ages 20, you're really seeing that it's affecting every age group, 20s, 30s, 40s. And as I'll get into in just a few slides from now, we're seeing it have a effect on our elderly population as well. And there's some theories and hypotheses around why we're starting to see we call it the bookends in data, where the young and the old are beginning to get more and more affected. And so certainly we want to keep an eye on that about why we're seeing seeing these effects in our youth and in our elderly population. But again, 20s, 30s continue to be a problem in Sacramento County in those age groups. Next slide I wanted to share with you is these are numbers of methamphetamine deaths. So again, we're talking about opioids, but as Lori mentioned earlier, we don't want to lose sight that methamphetamine continues to be the #1 used drug here in Sacramento and in many communities. And so we were able to get some data that's specific to methamphetamine deaths. And so I wanted to present that today as well, so we could really see of how these two substances are really, really affecting youth and adults in Sacramento County. So we're seeing here 191 meth-involved deaths in Sacramento. Ages here are a little bit different than the age profile that we see in the fentanyl and opioid deaths. Here around 50s, mid 50s to 60s, around that age group account for the lion's share of death. But again, as you can see in the data distribution here, really the difference between high in the 50s and over here in the middle are only 1 or 2 deaths. So again, this is a significant issue that we want to not lose sight of, that while we're combating opioids, we also want to make sure that we're combating methamphetamine as well, as this is the undercurrent is still very much there and affecting the lives of people in Sacramento County. So when we combine methamphetamine and fentanyl deaths, it looks like about 46 deaths are accounted for when both of those are combined. And again, looking at 30, 50, 20s, 30s, again, very much accounted for in almost every age group as well. But 30-year-olds tend to account for most of the death. And until we get into our 30s, mainly the combination has been seen in males. In folks that are male that die from a combination. So more males are dying from a combination use of fentanyl and meth than females based on this data. Wanted to highlight some of the data. This comes from our friends and our partners over at Song for Charlie. And again, if you haven't been able to take a look at their data, they have really great data sets, really great data analysis on their website. I put their link down at the bottom and I have it at the end too, but to make sure you take a look at their data as well. But I wanted to highlight this for folks on the meeting today, that we are seeing really a sweeping of fentanyl youth deaths across the nation. And I wanted to highlight over here on the second national map here that California had a 503%, and I highlighted that for folks. It's 503% increase in fentanyl deaths. So again, we're not seeing little increases here and there. We're seeing 500% increase. So this is between the difference between 2019, 2020 versus 2017, 2018. So again, a 500% increase over just barely 2 years. So we have a lot of work to do, both here in California and across the nation. Wanted to also highlight some more data from Song for Charlie that they shared with us. Drug deaths are accelerating, and as you may have heard in the past, there is some changes in the nomenclature around how we talk about drug abuse and drug overdose. A lot of the deaths that we're seeing in fentanyl related are folks that bought a pill off of Snapchat, for example, or somewhere off the internet. These are folks that do not have a history of substance abuse or substance misuse. They took one pill and they unfortunately died. And so really we're looking at classifying and talking about those deaths as poisoning versus overdoses, just because out of respect for family and because really these kids are not meeting the criteria that we would typically use to diagnose like substance dependence or substance abuse. These are kind of folks that are kind of took one pill and unfortunately died. And as you can see here, between 2015 and 2020, we saw an exponential increase in drug and fentanyl poisonings. And if you can see down here, firearms, motor vehicle suffocation, all the other ways that we typically see death, poisoning surpassed all of those. And so from about 2015 has gradually increased and now account for, again, the majority of deaths in our particular age group, in this particular age group we're talking about. And next one I wanted to share with you, is death related to youth. And again, we saw the youth between the ages of 20 to 24 see an increase versus youth 15-24 also saw an increase. And again, teens between 15 and 19 also saw an increase. So all three groups have seen increases related to drugs associated with drug-induced and drug use over the course of these 5 years. So just again, another data source just to kind of highlight that we're seeing these increases. They're affecting both teenagers and young adults. They're affecting a lot of different age groups. We typically didn't see significantly impacted by drugs in the previous decade or so. Wanted to also highlight this. I found this to be a very, very powerful statistical analysis here. So you can see in 2015, this particular graph shows kind of how much fentanyl really accounted for the larger substance abuse picture. And in 2015, you can see right around here, there was a little bit of it, certainly accounted for about 20%. But here in 2020, just 5 years later, this is how much fentanyl accounts for polysubstance and drug use in 2020. A particular age group here, we can see age groups between 13 all the way to 73 are seeing impacts based on fentanyl and deaths related to fentanyl. There are some racial impacts that we are seeing and continues to be present in the research that's coming out. According to a study of 4 states published in the American Journal of Public Health, a well-respected journal, Black people experienced a 38% increase in opioid overdose deaths between 18 and 19. And some of the preliminary data that's coming out of CDC and coming out of some other reputable sources are reinforcing this and seeing this trend continue. And again, according to the Opioid Research School, is that fentanyl is so potent, its spread has even hurt some of the most experienced drug users. So what we know is folks that have talked to us and said, I know drugs, I'm well experienced in how to do drugs, but fentanyl is simply a beast that a lot of folks just do not know how to navigate, and it's really Russian roulette. And we're seeing this really affect the urban communities, poor Black, Latino men who survived previous addictions and previous outbreaks and spikes in drug use. They're not able to keep up with how potent and how poisonous fentanyl is. And so we're certainly seeing this impact from a racial perspective. My data sources are there. Feel free to take a look. They're clickable links. Like I said, if you'd like this PowerPoint, feel free to reach out to me. I'd love for you to do some more research and take a look and follow these data sources. I think they can be very, very informative for the work that you're all doing. And like I said, I'll put my information up in the chat. And thank you so much for allowing me to present today.
Thank you, Andrew. This is Lori. I just wanted to say to the group that in behavioral health, we have a new behavioral health racial and equity collaborative, and we really want to make sure that we're bringing diversity to all the services and the work that we're doing, both through our Opioid Coalition means and through our Methamphetamine Coalition. And we will have an agenda topic on our next Meth Coalition having to do with that on an ongoing basis to make sure that we are reaching our diverse communities and we are talking about the impacts in these various areas across Sacramento. So thank you, Andrew, for addressing that.
And I'm going to hand it over to my colleague, Tricia Parker, who's going to be talking and doing a little bit more of a deeper dive and more specific data related to Sacramento County. Tricia?
Thank you, Andrew. Good afternoon, everyone. I'm going to be giving a brief overview of our substance use treatment for youth and kind of just going over the services and how we are treating opioid use disorder. So just kind of looking at our continuum of care for youth, we have our prevention services. These services really target all of our youth in our community. They really look at educating. There are many of our schools in the community. They do a great job with marketing and media to really combat the marketing and media that is targeted to appealing to the youth for substances. So they're really there to educate on the risk of substance use and kind of bring awareness to combat kind of the attractiveness of substance use. For those youth that qualify for treatment, we have a variety of services, starting with detox and withdrawal management. For these intense services, they are provided in the ERs with more of a medical management for them. And then we have residential. Here in Sacramento County, we do not have a youth residential substance use facility. However, there are many pieces of the puzzle, and we have about 3/4 of that puzzle put together to start our own residential here in Sacramento County. So that is exciting and more information to come in the future. We also provide outpatient services and intensive outpatient services. This depends on the hours per week that the youth is delivered services and what their needs, their specific needs are. Also, youth that have a opioid use disorder diagnoses can be offered medication-assisted treatment. And I'll kind of go over more of that in the next few slides. So again, for youth to meet treatment here in our substance use department, they need to have a DSM diagnosis. So an example is opioid use disorder. Many youth that have an opioid use disorder, like Andrew talked about, have polysubstance. So they often come with another diagnosis of marijuana use disorder or alcohol use disorder. which are two of the prevalent substance use that we treat here in Sacramento County. So our youth treatment providers are here. We have Another Choice, Another Chance, STARS Behavioral Health, also known as Capital Star, and they are also a TAY provider. They will provide services for individuals through the age of 26. We have WellSpace Health, Sobriety Brings a Change, and coming soon is Stanford Sierra Youth and Families. So we gathered a small sample on what are the youth saying, what are the providers saying out there in the community. And we do have our providers reporting an increase in opioid use from the referred youth. Also, they are reporting that youth are seeking out Percocet, knowing that fentanyl is laced or can be potentially laced with fentanyl. In addition, they are recently reporting that youth are actually seeking out fentanyl. It's much cheaper. It can be easier to access in many ways, and that is something that they're seeking. It's often reported that there's more of a euphoria with that and a risk that they want to take. And our CPS partners are reporting excessive use with the CSEC youth. Also, they're reporting with these youth that many of their friends, if they don't have Narcan on hand, if they do, they'll utilize that, but they will often use ice and other means to revive that individual. So it's almost like an awareness of the risk and their use of wanting that benefit and disregarding those risks. So a little scary to hear. So when we have youth that come in for treatment services, really what we're looking to do is a lot of behavioral techniques and interventions, which utilize evidence-based principles. Also, if there is an opioid use disorder, again, they have the option of MAT services for youth. Narcan distribution is something that we provide to the providers, an application. So our providers can complete the application and access Narcan for individuals in need. Also, we're working on early referral to treatment to really catch the youth early in their substance use. And a little bit more about MAT. So for those that are minors, there is a increased qualification for MAT. And the youth does need to have 2 failed treatment attempts to qualify for MAT. And then also 2 documented unsuccessful attempts at short-term detox. So there's a little more strict qualifications for it, but it is something that is available for the youth in our treatment services. And I'll open it up for any questions from anyone. No questions? All right, thank you, everyone.
Great, thank you, Tricia, really appreciate it. Okay, if you have any questions for our presenters as they're presenting, please feel free to add them to the chat. We can ask them at the end, or you can raise your virtual hand and I'll call on you. All right, so next up, I believe we have Bob Harris, who is the Director of Program Development at Harm Reduction Services in Sacramento. Bob received her Master's of Social Work from California State University in Sacramento and has worked in the field of social work for the past 17 years. And she's going to be sharing a little bit with you about harm reduction services and opioid use and youth data. So Bob, please take it away.
Oh, hello. Hi. Sorry, I didn't unmute myself. Thank you guys for having me here. Yeah, so Today, I appreciate you guys having me come talk about harm reduction in youth. I'm going to talk a little bit about what we do, what harm reduction is, some of the data that we have from 2021 for youth, and then talk about some of the barriers to harm reduction programming for youth and how we can kind of try to make that system a little bit better, if that makes sense. So let's see here. Let me get this going. There we go. So just so you're aware of what our agency does, we're one of 4 agencies in Sacramento that are doing syringe service program. And with that comes injection counseling, particularly for young people, because they tend to learn how to do things off the internet nowadays rather than, you know, from somebody who knows what they're doing. We also provide safer smoking and snorting kits that have like educational pieces with those to get people thinking about how they can reduce their risk. We also do HIV, Hep C, chlamydia, and gonorrhea testing with a risk reduction counseling session. And we also do weekly STI testing and safer sex education at Luther Burbank High School. They're the only high school that's kind of invited us to come and do harm reduction in regards to sexual health. We also do Ryan White medical case management for HIV positive people. We have a support group for HIV positive participants. We also have our education response and access program, which is our drug treatment navigation. And I think Rachel, one of our case managers, is actually on this call right now. And then we also provide safer sex supplies and survival supplies like wound care, hygiene kits, you know, over-the-counter cold and flu medication, which has been really important the past couple of years, and anything we can get our hands on that we can give out to people for free. We also do overdose prevention and response training, and with that comes naloxone distribution. And in 2021, we did distribute over 22,000 doses of naloxone, and our program participants have thus far reported for 2021 that they saved almost 2,000 people. So that was pretty awesome. And then we also partner with UC Davis School of Medicine for the Joan Viteri Memorial Clinic, which is like a 2-prong program where we're teaching incoming medical providers how to work with drug using populations, but then also we're creating an environment where there's a positive interaction for people who use drugs, who are seeking medical attention, who may have experienced stigma from like a primary care provider or something like that. And then anything we do in the office, we do out in the field, which includes our street outreach team, which is out in the field doing all this work 5 days a week. And then we also do a once a month street medicine program with UC Davis School of Medicine, where we take our students out. And we also do community cleanups. So that's kind of fun. So just so you know what we do. Okay, so I just wanted to go over basically what harm reduction is in a nutshell. So harm reduction is defined as a set of practical and realistic strategies and ideas aimed at reducing the negative consequences associated with drug use and other risk behavior. I like to call it compassionate practicality. And the idea is to meet people where they are, like emotionally and also physically. So some of the principles of harm reduction is a movement for social and health justice built on the belief in and the respect for the rights of people who use drugs. Does not attempt to minimize or ignore the real and tragic harm that can be associated with drug use. Drug use behaviors are on a continuum of severe use to total abstinence, and that some ways of using drugs are clearly less risky than others. And so I think sometimes people think harm reductionists are against abstinence, but what we're against is abstinence only, because we recognize that people are going to use drugs. And so we want to make sure that we're reducing any risks that they might have associated with that drug use. Some of the principles are non-judgmental, non-coercive provision of services, and quality of the individual and the community life and well-being, not necessarily the cessation of all drug use, is as the criteria for successful interventions and policies, which is a little bit different than I think some people might agree with. People who use drugs must have a voice in the creation of the programs and policies that affect them. One of the rallying cries is nothing about us without us. So they have to be involved in every aspect of programming and policy because it affects them. Affirms that people who use drugs are the primary agents of reducing the harm of their drug use. Therefore, they should be encouraged to share information and to support one another, because they're going to know better than anybody else, like what's working for them and what's not. And then recognizes that social inequalities affect a person's vulnerability to and capacity for effectively dealing with drug-related harms. And a lot of, like I've said before, one of the biggest things that we hear about harm reduction is that we are enabling people to use drugs. But that's obviously not true. We're just helping people improve their health wherever they are in their drug use, if that makes sense. So the CDC has actually done lots of studies on harm reduction programs now, and so we understand the efficacy of harm reduction. People who go to a harm reduction program are actually 5 times more likely to enter drug treatment than people who don't. They also reduce overdose deaths, obviously, because we're handing out naloxone and helping people strategize about how they can not overdose. And then it also prevents HIV and Hep C transmission in ER visits. The CDC also found that it supports public safety because it reduces syringe waste, which seems, some people think is counterintuitive, but they compared cities, you know, of comparable size and everything like that. And then cities that had syringe service programs had less syringe waste than cities that did not. And there is no increase in crime that they found if there's a syringe service program in a city. And people who go to a harm reduction program are more likely to reduce how much they're using or stop injecting drugs and go to smoking or snorting than people who don't. And then it's also cost effective because every dollar spent on somebody who goes to a syringe service program or a harm reduction program saves a taxpayer like over $7, which is, if you care about that sort of thing. And then just so you can look at some of the data that we've got. So these are folks who came and got services at our syringe service program. Not all of people that come to our syringe service program are injection drug users. Sometimes people do come for our safer smoking and snorting kits as well. So in 2021, we served about 952 people who were under 30, which is about 18% of our program participant population. And I would like to, yes, the gender and ethnicity, we can see all of that reflected also in the previous presentations as far as like representation. But then doing this for 10 years at HRS is how long I've been with HRS. The drug of choice kind of has changed a little bit for our participants. It used to be very distinctively like people who use opiates, people who use stimulants, so they actually used to kind of talk crap about each other. And now we're seeing a lot more polysubstance use. So a lot more people using both opiates and stimulants. And then, so this is not our data. This comes from the CDC. It's the California High School Risk Behavior Survey from 2019. And I like to throw this out there because I think sometimes, you know, we think of drug use and injection drug use as kind of like an older person's problem. But as you can see from the survey, they found that quite a few high school students do take prescription medications without a prescription or differently than how their doctor prescribed. And there is some experimentation with injection drug use, you know, during high school in California. And so I think that reality is kind of what I'm trying to put, you know, show the face of, because we can say abstinence, 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 but it's really, really important that we recognize that teenagers are using drugs and they need to be able to reduce their risk in doing that. And so that's something that harm reduction tries to achieve. This is some of our data that we've got. This is all of our participants, not just our under 30 participants, but I think it's an important set of data to kind of show people. Now, these are people who did end up injecting drugs. And so it's a little bit riskier type of drug use than like smoking or snorting or ingesting drugs. But they all didn't start that way, is kind of my point. So basically what we're looking at, we asked our participants 3 questions, like, when did you first start using opiates? When did you first use heroin? And when did you first inject drugs? And so for our population, you can see, I was actually surprised by this data. I thought it would be much later that people started experimenting with opiates. But as you can see with our population, it was very young, like 12, 13, 14, 15 years old. And you'll notice there is a correlation between heroin use and injection drug use because heroin is best injected. And then also you'll see that there's a larger spike of injection drug use the older that they get. And then part of that is because, you know, they might be leaving home, they may not have access to health insurance, and, you know, street drugs are cheaper, you know, than having to get them from a doctor. And so that's kind of why, and street drugs are best injected, if that makes sense. It's more cost effective, if that makes sense. And then they kind of talked about this, but this is also from this CDPH. I'm sure you guys have seen these charts, like a previous presenter kind of pointed this out, but this is the opioid related deaths in Sacramento. This is from 2020, and I think he had 2021 data, so that's awesome. But the point is that young people are using drugs, and they're at a higher risk for like HIV infection, overdose death, and like soft tissue infections if they don't know what they're doing. And so basically the argument that we're trying to make is that, yes, we need to have like drug treatment programs for young people, but we also need to be realistic about how we can, I always like to say, keep them alive so that they could make choices about drug use later on. And there is what I'm going to talk about next is basically from the Harm Reduction Journal up in Canada. It's an article called Developing Harm Reduction in the Context of Youth Substance Use. And they basically talk about some of the barriers to developing harm reduction programming for youth specifically, and then what youth say that they would like to see in harm reduction programming that they think would actually, that they believe would help them. And good. So basically, one of the barriers to having a youth-focused harm reduction programming is legality and a lack of knowing their rights. And so that's one of the things that, like a lot of young people, there are legal issues around, providing drug paraphernalia to a young person, even if it may be less risky drug paraphernalia than, like, say, a syringe, but we're not necessarily allowed to hand like a 14-year-old a pipe, if that makes sense, even though it's less risky than injecting drugs. But then also a lot of students don't know what their rights are. And so when we are working with young people, especially at the high school that we work with, we're not really allowed to kind of talk about their drug use. That's not really what our function is there. Our function is to talk about their sexual health. And even then, they don't know what their sexual health rights are. And in California, there's a lot of rights for young people around their sexual health, in the sense that you can access sexual health from the age of 12 on. But so there is an understanding, I think, in California of harm reduction around sexual health, but there's not so much an understanding about harm reduction around drug use. And there's also, that's basically the lack of political will to change the current curriculum around drug use. So it is very abstinence only focused. And abstinence is part of everything, but then sometimes that can not be relatable to a lot of young people because of whether they're using it for coping mechanisms or if they're just experimenting. And then there's also a fear of law enforcement and other authority figures as far as like whether or not they can access services for harm reduction. And then obviously parental rights over children. So parents, they love their children, they want to do the best for their children, but like I was saying with the understanding of harm reduction around sexual health in California, there are some parents who don't agree with that either, you know what I mean? But the reality is, children are using drugs and parents may not like that, but that's the reality, if that makes sense. But it will prevent their children from accessing harm reduction. And then the presence of older people at SSPs, because most syringe service programs are for 18 and older. They're not, because of legal reasons, we can't serve people who are under 18. And so they don't necessarily, even 18-year-olds and 19-year-olds are a little hesitant, this study found, to access syringe service programs because of the presence of these older people, and it makes them uncomfortable. And so it makes it a barrier. And then distance from program. That was one of the other findings that they had, was that like younger people are less likely to have a car or have transportation or feel comfortable using transportation to get, public transportation to get to harm reduction programs. And then paraphernalia laws, like I was saying before, right now in the state of California, it's not, you're allowed to have possession of syringes, but you can't have possession of a pipe. Which is a less risky type of drug use, or a snorting kit. Like those, especially for young people, they're not allowed to have those things. And so it kind of is like a little bit lopsided as far as the paraphernalia laws. So some ideas for creating harm reduction programming for youth. What the study found was that education about harm reduction and efficacy, we need to do education about harm reduction and its efficacy to parents and community members to kind of create that political will and understanding of like why it works and why it needs to be, in addition to treatment programs, there needs to be other programs that are being honest and talking about, how to reduce risk around drug use. And then also they found that it needs to be peer-led programming. Youth are more likely to listen to other young people. They don't want to listen to me. I'm 40 years old. They don't care what I say, and then they also said that avoiding using authority figures in the youth programming was helpful for youth who are using drugs to feel comfortable talking about their drug use openly, which is incredibly important when it comes to harm reduction. And then establishing programs in venues and locations that youth can easily access safely. Some of the suggestions from the study are like pharmacies, primary care clinics, schools, music venues, and festivals, because these are where young people are. And so rather than expecting them, because one of the principles of harm reduction is meeting people where they are. And so, expecting youth to come to a harm reduction program doesn't really make sense because they're not comfortable coming to a harm reduction program. So to bring harm reduction to where they are, whether it's in a pharmacy or primary care or school, or like having a booth at a festival or something like that, would be more effective for them in reaching youth. And then housing first, like, that's always a big one, is that, making sure that especially unhoused youth, which is a huge problem, making sure that they're able to get housing before we worry about all the other things. Because when we're talking about Maslow's hierarchy of needs, people can't even start to work on their mental health issues or anything like that unless their, physiological and safety needs are met first. And so that's huge. Expecting young people to work on their drug use while they're living on the street doesn't really make sense. And then incorporating harm reduction into health curriculum about drug use, sexual health, and general health, because harm reduction can be used for any risk reduction. And I think to make it like age appropriate, when we can start as young as, elementary school, just talking about seatbelts and sunscreen and using those words around harm reduction and because harm reduction is about loving oneself, and it's also about critical thinking, because we have to, as a young person, they're going to do risky behavior, but they can also develop critical thinking skills as they grow. And that's part of harm reduction. And incorporating it into health curriculum can help with that, to kind of guide that, if that makes sense. Oops, sorry. And then using social media that's relevant to youth. Right now it's TikTok and Instagram. Facebook is out for young people, I'm told by my Gen Z employees. This will change over time. And that is, again, why it is so important to involve youth in developing programs that are relevant to them in that moment, if that makes sense. So, social media is going to change, but that's why it's important to involve young people in the programming. And you can kind of see that. So we have one of our young employees who just started our TikTok last year, and already it's so popular. We have over 135,000 followers in our TikTok. So it's really helping to kind of get the message of harm reduction out there. And it's been really surprising how well received it is. And so this is my contact information. Add us on TikTok. It's literally just at Harm Reduction Services. We're also on Instagram. And so, kind of check out the kind of stuff that we're talking about on there and all that jazz. So thank you.
Great. Thank you, Bob. Looks like we have just a couple of questions in the chat. Again, feel free to raise your hand if you have a question. I'll call on you in just a moment. So the first question is from Yesenia. Is the program open to those who are homeless?
Program at Harm? Yes, our program is open to anybody 18 and over.
Okay. And then another question from Caitlin is, what is included in the safer smoking and snorting kits?
Sure. So basically what we include is instructions so that people understand kind of what is involved in all of the items that are in the kits. There's different kinds of kits because people smoke in different ways. So there's foil kits, and then there's meth pipe kits, and then, crack pipe kits. And so those are going to have different things in them, if that makes sense. But we have things like what we call a pipe condom or a pipe tip, so that like when you're sharing a pipe with somebody, sometimes the pipe gets really hot and you might burn your lips. And so you have a pipe condom, which is made of rubber, so that you can take it off, you're not burning your lips, and then you can pass the pipe to somebody, you're not spreading blood to each other. So things like that. Does that make sense? And then like the smoking or the snorting kit will have like a dedicated surface to snort your drugs off of, rather than going to the club and snorting off the back of a toilet or a counter or things like that. And then there's also things included like different colored straws so that when you're snorting with your friends, everybody had, like, I'm blue, you're red, this one's green. Sense. So the idea is not just to provide the equipment to people, but it's to get people thinking about how they can care about themselves and reduce their risk when using drugs, especially with other people. So there's a lot more things in the kits, but that's just an example. You can come by and check one out. Stuff on fire.
Great. Thanks. And then it looks like Lori, your hand is up. Please go ahead.
Yeah, I want to say thank you, Bob. It was nice meeting you virtually. I know we talked on the phone and I had some email exchanges together, but a couple of questions from the county level. You spoke about the drug trends in terms of seeing polysubstance use, your opioids, and your stimulants. And in terms of the stimulants, are you seeing methamphetamine? I heard cocaine's coming back a little bit. I'm hearing through the grapevine, so I wanted to hear a little bit more about that through our partners that offer data to us, just so to make sure that, you know, we're kind of aligned with what's out there.
Yeah. And I think Sane's on here. I think Franz is on here too. And he might also have a lot of information. Sane is another one of the SSPs in town. So just FYI, he's a good person to, you know, tap into his brain. But yes, we're seeing methamphetamine, cocaine. Yeah, absolutely. Methamphetamine particularly. Okay. And then you mentioned some of your services are community cleanup. So we get a lot of calls at the county, you know, needles everywhere, a lot of concern from neighborhood associations and partnerships about, you know, working together to get neighborhoods cleaned up. So if somebody does call us, are you or other harm reduction organizations able to go out and get that stuff cleaned up, or is there another process for that? So we do, if somebody calls us and tells us that there are syringes in their area, we will go out there and pick them up and then do outreach and hand out, you know, sharps containers and such. But I do believe the city has a service for biohazard cleanup. And I can't remember, I think it's called, oh, Rachel, do you remember what it's called? Sorry, Franz, do you know what it's called? The city does, they actually hire somebody to go out and pick up. We will do it if you call us, but just be aware that we are a agency of 12. So we do not have a large capacity to do huge cleanups, but the city did hire somebody, an agency to do that. Okay, I'll look into that. I was just curious. And then last question, when young people are coming into your organization, how much counseling do you provide? Are you encouraging counseling and enter into treatment services? I know your harm reduction and all your services are great in that respect, but I'm curious about the percentage of referrals to county treatment programs and how much conversation is happening in those areas. And then just to make your staff aware, and you can maybe connect with Tricia at a later time, we provide substance use disorder assessments by phone now. So if you have a young person that you're seeing that maybe will be open to treatment, you can get them connected that moment that you're in a conversation with them. So I think it's really helpful right now and a benefit, having this telemedicine, telehealth option for young people. So I'm just curious of what percentage are you seeing are young people open to it? So the way that we work all of our programming is that when somebody comes in to our agency, sorry, I'm taking up a lot of time, so I feel really bad. But when somebody comes in, especially if they're new, they may not feel comfortable talking about their drug use. I think sometimes when people come in, they're very shocked by how open we're being with other participants who've been coming to us for a while. Like people come in and use euphemisms for like pipe stuff, like, you know what I mean? And we're just like, oh, you mean like methamphetamines? And so that's kind of uncomfortable for some people, but over time, we basically have to gain trust and like that they feel comfortable opening up to us about their drug use. Rachel, who's on the call right now, is our drug treatment navigator. Her advertisement is there. Everybody who joins the program is told of all of the services that are available, but we do not push treatment on people. But she is busy all day long. And so it's not an issue. Like people who are ready to talk about treatment, they know that they can talk about treatment with us, but they know that we're not going to push them into anything that they don't want to do. So when people do ask for Rachel's services, like they're ready to go, and then she takes care of them. And she does navigate people into the county sometimes as well. But we do work with other partner clinics, buprenorphine clinics like Sane. So I hope that answers the question. Yeah.
Yeah, and then last question for Lauren and Lindsay. TikTok, Instagram, Snapchat, that seems to be kind of the direction. So I know we're focusing on youth in this particular opioid coalition meeting, but do we have are we putting social media and those those platforms, information around, the increase in, educating around the dangers of fentanyl, anything that's impacting our young people? Are we able to do that?
Yes, so we do have all the social media channels covered, and we actually have a campaign that's ongoing on TikTok in particular that it's a 15-second ad that we've been just buying ad space for about fentanyl. And it goes directly to the Opioid Coalition page that lists all the different resources and medication-assisted treatment that's available. So it's interesting because one of the reasons why we're focusing on youth in this particular program is that the vast majority of clicks we've had have been from 14 to 17-year-olds locally here in Sacramento. There were just in a month span, there was over 150 clicks in that age range that clicked on the ad and went to our website. So it's definitely gaining some traction with education. So I do encourage everyone that's on the call today, if you have resources or things that you would like for us to push out into the community via social media, you can either email me or actually preferably Lauren. Lauren, if you wouldn't mind throwing your email in the chat, she's our AmeriCorps Vista. She handles all the social media for us. Thanks,
I do
Lauren.
have a suggestion.
Sure.
I am 40, and so I know nothing about the trends
Me
on
too.
TikTok and things like that. And so we made sure to put in charge of our social media somebody who is of Gen Z, because there are like weird TikTok trends and things like that happen, like certain songs and things like that. So I highly recommend like tapping into like some Gen Zers, if that makes sense, on your
Well,
stuff.
we have, yes.
Yeah, good,
Yes.
good.
At least with our channel, Lauren
I don't understand any of it.
and Marley, our previous Vista, they're Gen Z. So, and I'm definitely not either. So
Yeah, there's some I don't understand, but it makes sense to them.
Well,
Yeah, something
wonderful.
to
Go ahead, Lauren.
something to know with the TikTok that Marley's been working on. The number of clicks that she got for 14 to 17-year-olds within 5 months of last year was over 206,000.
That's crazy. Okay. All right. Well, Bob, again, thank you so much for joining us today. I think it was just really beneficial for everyone on the call. Okay. So next up, we have a lived experience. So we're going to hear from Jacob Ward, who is a writer and youth mentor. And he is 28 years old and a recovering opioid user. So he's actually a youth mentor and writer, like I said, and he aims to reduce the stigma surrounding teen opioid use by offering his very unique perspective. So Jacob, you are up next.
Thank you, Lindsay, for the introduction. Hello, my name is Jacob. Thank you so much for having me and for giving me the opportunity to share my lived experience and battle with opioid addiction as a teen. Just a little background, growing up, my home life was really turbulent. Like many teens, I was part of a split family. My parents divorced when I was 7 years old. I lived with my mother, who had full custody of my sister and me, and I rarely saw my father. When I was 10, my mom remarried, and I thought the life was going to get a lot easier. Instead, I found myself exposed to constant and verbal physical abuse from my stepdad. I found solace at school through sports and spending as much time as I could at friends' homes. Being from a low-income family as well, I was often told that focusing on my grades and being good at sports would allow me to receive scholarships for college, where I could study and land a job with a good salary. I dreamed of moving away after graduation and put all my energy into what I felt I could control. At the age of 14, and as a teen, I was first introduced to prescription opioids during my freshman year of high school through my involvement in my school's Division I water polo team. Injuries were common, and the pressure to continue to play while injured was bred from the highly competitive nature of sports culture. A couple of my team members had access to prescription pain medicines at home from family members who no longer needed them, but kept them in the medicine cabinet. Until then, I had only ever heard of these medications through the DARE program at my school. This program was taught a week out of each year, starting in middle school, and focused on promoting the fear of drug use by showing the long-term effects of using illicit substances. I felt like there was a serious lack of information regarding how addiction began and how casual use could spiral into physical dependency, and no real information about who to turn to for help. I remember the very first time a teammate offered me a Norco. I had suffered a serious shoulder injury to my dominant arm, which made playing pretty unbearable. I was sometimes taking 8 to 10 ibuprofen before practicing games and would still wince from the pain when I moved a certain way. After practice one day and before a big game, a teammate offered me 2 5-milligram Vicodin and said that they were safe and were encouraging about their ability to help me continue playing free from the pain of my injury. They instructed me to take them about 30 minutes before warm-ups the next day, and I trusted what they said. The following day, I took the pills as they recommended. I was shocked at how well they worked. The pain was completely gone, and I played one of my best games. We won, and after that game, we went out for dinner as a team. I was feeling great, and I slept so good that night. I was free from the normal aches and pains that I had been experiencing. However, I was really extremely disappointed when I woke up the next day and realized that the agonizing pain in my shoulder had returned. I took a couple of Advil before school and went about my day. When I met up with my teammate the following day, I told him about how much the Vicodin had helped me, and he offered me a couple more just to keep in case I needed them. As time progressed and my injuries never allowed to fully heal, I found myself always having a couple extra Vicodin tucked away in my backpack for the bad days when my body ached and I felt the pressure to show up and play anyways. I felt it was safe only using them as I needed, kind of like a Band-Aid. This seemed casual to me, and my trust in the substances grew. I never experienced any withdrawal symptoms, and I felt like I knew what I was doing and how to handle this newly found super pill. At the age of 17, I was involved in a traffic accident that left me with a severe back injury. At the time, I did not have proper medical coverage that I needed to be able to seek treatment, and I knew that my hopes of playing sports in college were through. I turned to these medications as a way to self-medicate. I had access to stronger medications at this point, like morphine from a friend's mother who was terminally ill. I spent a lot of time at their house, and she had a surplus of medications being prescribed to her that she kept in the house and would offer them to me to help with the constant pain I was in. Over the course of the next year, my senior year in high school, my dependency grew, and I started to feel really sick every morning. I was taking between 3 to 5 20-milligram morphine each day. One day I came to her sick and withdrawing from the medication, and we had a conversation where we decided that I would no longer be able to get the pills from her. I was already deep in my bouts with addiction and experiencing severe withdrawals, so I began buying pills from street dealers. However, these were incredibly expensive, and from recommendation of a dealer that I trusted, I turned to smoking heroin. Having initially misunderstood the dangers of these medications that were glorified by my friends, I quietly internalized my struggles with my addiction, not really knowing where to go or who to turn to for help. After graduating high school, I went to my local Cal State University. I had been living on my own for most of this time. I was falling behind in school, and every day at my job in a pizzeria was a struggle. I would try to stay well enough and keep the withdrawal symptoms at bay so I could complete my tasks and keep enough money coming in to support myself and to pay my bills. My habit had become increasingly more expensive as my tolerance grew, and I started selling my personal belongings, which allowed me to get the money I needed to support my habit. At this point, I had become incredibly socially withdrawn. I was hiding from my friends from school and family members. I was living with the constant fear of withdrawal. I had a desperate looming feeling that I was going to lose the life that I was so desperately trying to make for myself. It seemed like I was traveling alone in a dark cave. The only people that I was hanging around with at this point were people who wanted to pick up from the same dealer that I did. We were all around the same age, about 17 into our early 20s. We would buy together to reduce costs as much as possible. Most of the people that I was hanging around with were all IV users. There was one night in particular that was burned into my memory and still haunts me to this day. It was a hot summer night, and we had picked up from a person that we usually didn't buy from. After returning to the house, a few of the people I was with began preparing their dose. Shortly after administering a shot, a young man who I'd come to know and befriended became unconscious. His breath was shallow, almost non-existent. Panicked, and one of the people who lived at this house called 911. Those of us who didn't actually live there were so scared of getting in trouble by the police that we left. None of us knew what was going to happen to him. A couple days had gone by before I found out that my friend did not make it back from the hospital that night. He passed away from an overdose, and I was heartbroken. This was the first person and the first friend that I had ever lost to this disease, and this became a huge turning point for me. Outside of this group of friends, acquaintances that I had been spending so much time with, I had one friend whose house I would spend some time at who wasn't an addict or addicted or used substances at all. One day I was there at that house and a neighbor came out to the parking lot where I was and caught me smoking in my car. I quickly tried to hide my things. They approached me and let me know that they ran an inpatient rehab facility and asked if I wanted to get help. They actually invited me into their home where they explained to me the process, different treatment options that were available. As much hope as this gave me in that moment, I didn't think it would work with where I was in my life. I was fearful of losing my job, losing my housing, and having to come out to my family about the struggles that I was facing. I thanked them for their time and for the kindness that they had shown me. And ultimately, I knew I didn't want to live like this anymore. Desperately, I tried reaching out to anyone who I knew who had gotten clean and asked them for advice. I tried to quit many times quietly on my own. I would stop dosing on my days off work and would allow the withdrawal symptoms to set in. I had heard that it would only take a few days to go through detox, but the feeling was truly unbearable. I was so sick, shaking in cold sweats, my body constantly ached, my muscles were tightening in horrendous cramps. I would try to drink water or eat, but my body rejected everything. As my next work shifts would come, I would give in and smoke just enough to get me through the day. After a year and a half of living in this vicious cycle came a day when the person that I was picking up from wouldn't answer my calls. I was feeling absolutely horrible and had already been experiencing withdrawals for about 2 days. I had to go into work and was terrified of not being able to make it through my shift. That day, my boss actually noticed how bad I was feeling and had made a comment to me that I seemed like I was sick often. This caused him to open up to me about his own struggle with addiction, where he let me know that it was possible to get better and that he would allow me some extra time to seek help, and that I would even have my job still, after I went through treatment and got better. This is the hope that I was looking for, the light at the end of the tunnel. He told me that I could take off as much time as I needed. He sent me home that day from my shift, and we decided that I wouldn't be scheduled to come to work for a couple weeks. I knew this was my chance to finally get clean. I called a friend who I had confided in, and they told me that I could come to their place to rest and go through the process of detoxing. I spent the next 3 days in complete agony. I couldn't sleep, I couldn't eat, I couldn't drink. I really felt like I was dying. And on the 6th day, I knew that I could no longer take this on alone, and I wanted to seek medical help. Reluctantly, I called my grandmother and told her what was going on. I asked her if she could keep it a secret and take me to the hospital. I told her where my friend's house was and asked if she could pick me up. About an hour later, she arrived with my mother, who was absolutely hysterical. I felt like my world was crumbling in, and all I wanted to do was just get better. We went to an addiction treatment facility, but since I was already so far within the withdrawals and detox, normal medical assisted treatments like methadone or Suboxone were no longer an option for me. Instead, I was recommended to go to a different doctor who could help me with where I was at in my journey. When I arrived, he took my vitals and asked a litany of different questions about my use, duration, amounts, and other specifics of that nature. He prescribed me clonidine, which is often used to help withdrawal symptoms, and the symptoms that I was experiencing. This was such an enormous help for me. That night, I was finally able to sleep in what felt like the first night in like 6 days. I woke up feeling like I could actually conquer the beast that I was fighting. It was only after coming out to my family about what I was going through that I learned of my family's history with heroin addiction. The youngest of my grandmother's 2 brothers is a recovering addict and an addiction counselor, and he actually met with me after I went through detox in support of my struggle and my experience. He shared with me the dangers of relapse and also cautioned me about how important it would be to develop healthier coping mechanisms for the rocky road that lay ahead. I had also learned of another family member who was no longer with us that had battled with addiction as well. It was both sobering and unifying to be able to relate to my family in this way, but I was also kind of curious why I was just learning about these stories. They offered me so much insight into my own struggle and through sharing similar experiences and the battles with withdrawal and relapse. In my 8 years of sobriety, I have learned of more than half a dozen people that I had become close to or was acquainted with during my addiction who have since died from overdose. I've heard countless stories that resonate with me from young people that are facing their own battles with opioids. the common thread being that they never start out with the intent of becoming addicted. From friends recommending them to glorification in music, these drugs seem like they may provide answers to people's problems. And I just hope that my story has allowed light to be shown on to how easy it is to be trusting of these dangerous substances. There's a huge need for greater transparency in our community, a need for difficult conversations that can't go unhad. There's a need for more safe spaces that provide an opportunity for harm reduction through honesty and non-judgment. And there is a need for more resources for teens and young adults on the options for recovery and also on the approachable treatments. By reducing stigma, connecting resources, and creating a more caring, open, and compassionate dialogue, there is a way to make progress down the path towards healing as a community. I just want to thank all of you for providing this space, and I appreciate each and every one of you for your time and energy. I'm very grateful for those that have shared such valuable insights into what is going on in the current chapter of our opioid epidemic. So thank you for having me.
Jacob, thank you so very much for sharing your story, your very personal story. As you can see, if you're looking through the chat, many, many, many thank yous from so many people that are on the call today. Just going to scan through here to make sure that there aren't, oh, I found a question from Allison. From your perspective, what are some good ways to support those in their recovery process while keeping boundaries?
Ooh, that's a really good question. I think that probably one of the best ways is being able to hear people's firsthand accounts just provides a more trusting environment where people can open up. And so just like Bob was mentioning at Harm Reduction Services, just, creating a safe space and an environment where people can have that open dialogue where there's not an authority figure around, just builds that trust and allows for those boundaries to maybe be broken down just a little bit. That's what really helped me. It was, being able to come out to my boss and have him be honest about what was going on. I think was definitely a huge turning point for me. Thank you.
Great. Thank you again, Jacob. We really appreciate it. Okay, so hopefully everybody's hanging in there with us. We're going to move on to our last speaker, last but not least. Next up, we have Sherry Egeland, and she is currently the Associate Director and Research Specialist at Omni Youth Program. She's been with Omni for over 15 years, where she trains and teaches professionals, teens, young adults, parents, and families about alcohol, tobacco, and other drug prevention. She has been working with and supporting youth and families in the Sacramento area for the last 30 years. So Sherry, you are up, take it away.
There we go. My unmute button wasn't working for a minute. It scared me. I'll go ahead and share my screen here. Okay. Come on. Everybody good? Can see that? We're good? Okay. Yay. Well, so how long do I have, Lindsay? I just wanted to check in on that.
We gave you 15 minutes. We're gonna run a little over for those that want to stick around. I hope they do, because we are recording this.
Okay. Well, brevity is not my strong suit, but I will do my very, very best. Thank you so much for having me today. As Lindsay said, I am Sherry Egeland. I'm the Associate Director at Omni Youth Programs. Feel free to write my email down if anybody, I'm happy to share these slides. I'll go ahead and send them to Lindsay after, because there are some links and things that you might find helpful. We are located, our physical office is in Sacramento here. We are one of the 4 prevention providers that are funded through Sac County. So thank you so much for that. Feel free to check out our website. We have a lot of online resources, a lot of quick videos on our YouTube channel that you can get. We have a really good blog that's written firsthand account by some of our younger staff. We were just talking about the importance of the perspective of the younger generation. And there's some really good resources on there. So feel free to check that out. Before I start talking, they did ask me today to talk about some of the signs that parents and other adults can look for in young people that might be thinking about using drugs or starting to use drugs or are using drugs regularly. So I wanted to make sure before I start and say, you know, a lot of these signs are just make kind of a general, so it can be kind of difficult as a parent because you want specifics, but the important thing, whether you're a parent, a caregiver, and a parent doesn't have to be a biological parent by any means. It can be somebody that cares for that youth, that has that role model kind of relationship with that young person. But most importantly, throughout this presentation is to consider, you know, your child better than anyone. I know they've changed a lot. Those teen years, they come, sometimes it feels like they go in their room and come out a completely different person. But in terms of the behaviors I'm talking about, please consider that you know what's normal for your child. So when we're talking about changes in behavior, we can't just make a broad statement for all teens, but trust your instincts on that. You know when something's up, but I'll try to get as specific as I can. So if you're talking about personality and attitude changes, which is so fun with teens, if you look at this stuff, it seems like, well, that's every teen in America. But remember, we're talking about some extreme kind of sudden changes, nothing gradual. So behavior that's out of character and kind of consistently out of character, not just, you know, feeling off one day or maybe hormones are raging one day. A kind of sudden change in friends, maybe friends that they've been friends with for years, just really suddenly they've cut off from and they kind of are hanging out in a new group that you're not too sure about. Really extreme personality and especially the attitude of, you know, I don't care, no big deal. And again, extremely erratic behavior, like you think of like a roller coaster, you know, not a gradual drive up, you know, through the through Lake Tahoe, but more, you know, sharp up and downs. And just more hostile, especially if you're asking them about things about where they've been or what's going on, and really just seems uninterested in things that they used to be interested in. Now, interests change, just like, you know, my interests change sometimes, but we're talking about uninterested, but then not interested in anything else, not substituting, you know, you used to really like skateboards and now you're really into BMXing. That's okay. But if you used to really like to go out and skateboard and now you're spending every day in your room, you just don't care about it. That's kind of more what we're talking about. Behavior changes, this is things that they're actually doing. If you're noticing money missing, I know I'm kind of absent-minded and my team knows that she can go in and get $5 out of my wallet for lunch, but we're talking about kind of major, you know, if you're noticing things, especially kids are really good about using digital currency. So you do want to keep an eye on like your Venmo accounts and things like that to make sure that there's not things going and coming that you don't know what's going on there. Especially, you know, Jacob mentioned, thank you again, Jacob, for your wonderful sharing today. If you notice that they seem to be selling off a lot of their stuff, that's even like game systems and things that are kind of worth money. And even around your house, if you're noticing all of a sudden, hey, where's that camera that, you know, things like that kind of they could trade in for money. If you catch them lying a lot, again, I know every teen, but if it's more of a secrecy lying, like they're not honest about who they're talking to or where they're going, they're locking their door a lot more frequently than they used to. If their schedule changes, meaning like, you know, they used to kind of like to sleep until maybe 10 and they were up till around midnight or 1, and then all of a sudden they're sleeping until 1 or 2 in the afternoon and they're up till 4 or 5 in the morning. Those are kind of what we're talking about. A dramatic change in appearance, maybe especially hygiene isn't as well. And out of place clothing means basically they're not dressed for kind of whatever the weather, the environment they're in. They're dressed really warm, you know, on a hot day, or they're just short sleeves and shirt, you know, on a really cold day, because drug use, and especially when you're going through withdrawals, that can really mess with your brain's ability to regulate your temperature. And they also might be trying to cover up, especially if they have gone to needle use, they might be trying to cover up signs of that. Physical evidence, if you notice discoloration or burns on fingers, that can be sometimes from pipe use. Like Bob mentioned, sometimes burns on the mouth can happen. Of course, track marks or sores that look like they're not healing very well or just look, you know, kind of out of place. Really bloodshot eyes. We're not talking like a little bit of, Monday morning redness, like really bloodshot eyes, and drug paraphernalia. I will tell you, it's getting trickier and trickier to know as an adult, what is drug paraphernalia? There's so much stuff out there that makes it so easy for our young people to use in secret. I just did a hidden in plain sight presentation for Twin River School District last week and kind of demonstrated some of those items, which I'd be happy to do with anybody that's here. Please feel free to contact me. I can do that for your group or anybody that wants to, but it's quite amazing just on Amazon, the things that you can get to kind of cover up that drug use. Physical evidence that you might just notice looking around, and a lot of items that are used to cover odor. Why is there 5 empty cans of Lysol in my son's room? Or, my son, hasn't cared about candles his whole life. Why is there 10 candles in here? Things like that. If they're kind of hiding when you walk in the room, they put their phone down or, slant every single time. It's something to be concerned about. And again, I want to reiterate, you kind of know your kid and when your brain goes, that was weird. He doesn't usually do that, or she doesn't, or they don't do that. Trust yourself on that a little bit. And it could be other things, but especially if you're seeing some of this stuff, you're seeing this behavior in conjunction with other behaviors, if they kind of start stacking up, that's something to kind of take notice of. But drug nicknames is something to try to keep yourself aware of. It can be really tough. All of these little things that you see down here, Zerp, Tabs, Ice, Orange Tesla, those are all drug names and talking about drugs. Like Loud, if you said, hey, I love Loud, or I'm looking for some Loud, that means you want some really high potent marijuana, for instance. It's so hard to keep up with that. I did put a really good resource there that, again, I'll send this to Lindsay if you guys want to use it, but you really can, use Google or whatever source you use for that. Look those up. If you see stuff like, why is he talking Orange Tesla? That's weird. And like you see, we all know about the 420, for instance, when it comes to marijuana. Oil is the new 420 because if you flip, 710, is the new 420 because if you flip 710, it says oil, which they're talking about the high potent marijuana, like high contact. So that's just an example of how things kind of change. And again, I'd be happy to come back and talk about drug slang if that helps. Any of this stuff I can do. Now, in terms of drug seeking behavior, meaning that this is something that a lot of times people who are using drugs or really are kind of addicted to that, some of the things they do, if they're asking, especially if you're at the dentist or the doctor with your teen, and they're asking for specific drugs by name, they seem to be requesting higher doses, they're claiming that they're allergic or no, that drug didn't really work. I really like, I really kind of won't go for the oxycodone, that worked better. If they're claiming that they lost or somebody stole their prescription, I had it in my backpack and they stole it, if you're kind of noticing that more and more. And when you're at the physician, especially with them, you notice that they're concerned about that prescription. They're kind of wanting to get to that, tell me what you're going to prescribe me, more than finding out maybe what's the diagnosis is or what some of their treatments are. There's some very specific signs and symptoms of opioid abuse. I don't have a ton of time to go through them all, but again, they're here and I'll send that to Lindsay. But specific to opioid abuse, a lot of confusion and disorientation, slurred speech, decreased perception of pain is really high because opioids can kind of that's what they do, is they help us not experience pain. So if you notice, maybe they just grab a really hot cup or, really warm bowl of soup and don't seem to notice. Drowsiness is a big one, kind of their head nods. They seem to be sleeping a lot more and kind of just really breathing slowly. Some severe weight loss, their eating habits change. If their constipation is another one, because opioids and really all prescribed pain relievers can really kind of dry you out. They really dehydrate you. So that's something that you might be noticing. A decreased, again, perception of pain, any kind of muscle movement or total loss if your blood pressure goes down really low, a body temperature below 95, or a heart rate under 60 beats. That's something, if any of that stuff's going on, I personally would recommend, I'm not a medical professional at all, but I would recommend really seeking medical help if any of that stuff's going on. Another thing with appearance is the pupils are constricted, especially if you shine a light or they're outside in the bright sun and they have really tiny pupils. The coordination, itching and scratching is kind of a result of, being like opioid withdrawals a little bit. They tend to itch, especially if there doesn't seem to be, mosquito bite or any reason they're itching. And lots of sweat. Sweating is one of the biggest kind of soonest withdrawal symptoms. And again, emotional, severe mood swings, feeling really euphoric and then feeling really upset, poor decision-making, and really kind of abandoning responsibilities. Maybe they were a really good big brother or sister, or a really good friend that used to watch out for things or take care of the dog. They walk the dog every single day and all of a sudden they don't care about that just overnight. Here's a little bit just to let people know in terms of if somebody is going through opioid withdrawals, it happens pretty quick. That's why these things can, 6 to 12 hours, you can start feeling withdrawals. That's, really soon for it, depending on the opioid that you're using. And then 30 hours for longer. And then 72 hours seems to be kind of the time when a lot of the symptoms peak in terms of vomiting, stomach cramps, things like that, drug cravings. And then if you go past that, in terms of a week or 2 weeks to a month, these are some of the physical symptoms kind of start to lessen after about a week, and it's much more psychological about week 2. And this can continue for a lot longer than a month, but this is just kind of a breakdown to let you see, especially it's a good idea to encourage your child to, if they are experiencing depression, anxiety, any of that stuff, if they can talk to someone, if they don't feel comfortable about talking to you, but if they have been using something and they're not using anymore, that could be the reason. So you could sometimes avoid needing to put them on depression or anxiety meds if you kind of figure out what their history is with that. And especially offering them the right to be honest with the physician about that without you knowing as the parent, that's up to you. But that's something I know some parents have done. There are home testing kits out there because some parents tell me, how do I know 100%? I really think so, but I'm not sure. Unfortunately, this is kind of one of the main ways, but fortunately or not, depending on how you look at it, these are available just about anywhere. Walmart, Target, Amazon, you can get a lot of these drug testing kits and they do test for opioids. Another one that we've just become aware of called Verafique. They just opened it up. They just started doing this in October, but they're unique in that you don't have to necessarily test urine or crush the pill to notice. It's basically like a pen that you rub on the object, the pill, or they're doing these gummies here. And then there's a strip that you rub the pen on. And depending on if it turns color, it'll tell you if there's THC is one of the testing kits, or fentanyl. That's the two that they have. They have THC and fentanyl testing. So I don't want to testify about the validity of this stuff because again, it's new, but it is something that's out there. I did want to just say this just came across my desk and I wanted to make sure and share it with you all today. A lot of parents ask me, well, where are they getting prescriptions? I thought doctors were up on this. What's going on? Well, there was a study in a WebMD that basically they combined a bunch of different surveys on this and found out that 60% of emergency visits with dental disorders ended up with an opioid prescription. And these are for young people. These are for teens and for young adults. Among young adults, the drugs that were prescribed about 38% of emergency visits for lower back pain. Because again, that's something that's hard to, you can't really tell with an x-ray. And they're much more likely to get prescriptions in the emergency room compared to an office visit. So it seems like emergency rooms are the places, especially if your kid's going to go to the ER. Most parents would go anyway, but you definitely, I would suggest having an adult there with them. And one of the things that we do have on the Omni website is a little postcard that we made, the Sacramento County Coalition for Youth developed. And it basically has 10 questions to ask if you're being prescribed an opioid. It's meant for parents and teens. So you can go on and get that, or you can go to the SCCY website and get that, just to kind of hand out to parents so that they have that with them. And for teens, most often it was either a dental problem, a collarbone, or broken ankle were the reasons they got opioids. And for young adults, it was dental pain or lower back pain and neck sprains. And just a heads up too, I always like to tell adults that it's not kind of, hey kid, come here, kind of drug dealer where they're getting the stuff. A lot of the times, as Jacob shared, it's from friends, it's from people they know. And it's usually from somebody's home that a lot of the prescription drugs are being gotten. So that's why we suggest, if you do have opioids in your house, especially if you have young or vulnerable people, that you purchase some kind of, there's a pill lock. They could go for individual bottles, but there's also just cases that you can buy to lock things up. You know, there's gun safes out there. There's all kinds of ways that you can lock things up, but we strongly recommend doing that for opioids and especially stimulants and things. And again, I can come back and talk about this, but at prevention, we really encourage talking early and talking often. We tell parents, educate yourself, try to find as many positive influences versus negative. Find healthy opportunities for challenge, because that's what kids are looking for. And the biggest thing, a lot of surveys or studies are coming out now saying that the biggest thing that seems to help young people avoid drug use is practicing and learning skills to resist peer pressure. That seems to be working really well. So here's some really good resources that I like. Alternatives to opioid pain. There's a really good opioid toolkit for parents, how to protect kids from buying meds online, because that's another one. I could come back and talk about that too, because Instagram, especially recently, was just busted for that. They had an undercover operation that basically figured out, they pretended they were 12 to 17-year-olds, and it took about 20 seconds before a drug dealer reached out to that person offering them opioids and basically whatever they wanted. So I can come back and show evidence of that. But there's an example of that 12 questions, a little postcard that I talked about earlier that you can again get off of our website or the SCCY. Here's some other warning signs and prevention tips and resources for young people that are there as well. And thank you for having me. There's mine again, and we'd be happy to come and do any kind of presentation that, you know, would be helpful. Thank you.
Carrie, you're amazing. We definitely should have given you more time, especially looking through your slides. So we'll definitely have to have you back so you can have a bit more time to go through this. For those of you that heard earlier, Sean Vassar from the U.S. Attorney's Office talked about that we are having a summit for an opioid summit for educators. And Sherry will actually be one of the speakers at that, going over a lot of these warning signs for educators to look out for. So does anybody have any questions for Sherry? I'm just gonna glance through the chat here. I don't see any. Yeah, we need to put you at the beginning so we can pick up, you know, have everybody on and have all the time for the questions. All right, so wonderful.
Put my email in the chat there. Just anybody can email me anytime for if you want more information about anything that we talked about, or you know, anything like that. I'd be happy to anytime.
Wonderful. Thank you so much, Sherry. And again, thank you all for joining us today. I apologize that we went over, but I felt like it was worth it, so we did. So please mark your calendars for April 18th from 2 to 3:30 or 3:45 for our next Sacramento County Opioid Coalition meeting. We'll be sending out invites and reminders coming up here in a month or so. So again, thank you to all the speakers, and thank you all for everyone who stayed on with us for the extra 10 minutes. Appreciate it. Have a good afternoon.
Bye. Thanks, everyone.